We're here at the CROI, the Conference on Retroviruses and Opportunistic Infections, the 21st CROI here in Boston. And we're here with a distinguished panel who are going to talk about the science of PrEP to implementation. We hope that we will cover this in a way that is going to give us a robust picture of the whole picture from the very beginnings of it to the point where we're now trying to bring it into the mainstream of the United States. So I think Myron, you were going to start off with, well, let me first introduce everyone. Myron Cohen, or Mike Cohen as you call yourself, from the University of Chapel Hill, or the University of North Carolina, Chapel Hill, and Dawn Kabuta, which is she works with the Department of Health, Massachusetts, and Jonathan Merman, who is the director of CDC, the
National Center for HIV, Viral Hepatitis, STD, and TB Prevention.
At the CDC?
Yes.
Okay. And Carl Diefenbach, who is with NIAID in Washington, D.C. at the NIH, myself, and Dawn Smith, who is also working with the CDC. So we got that. Mike, if you could give us a little bit of background on how the science went.
So there's a context. Antiretrovirals are a terrific set of discoveries, and we have lots of drugs now, but we started with one a long time ago, and over time it became clear you could not just use antivirals for treatment, you could use them for prevention. There are three ways you could do that. For post-exposure prophylaxis, which has been used extensively after needle stick injuries and such. Treatment as prevention, by treating people, rendering them less contagious. But today we're talking about a kind of third opportunity, and that is pre-exposure prophylaxis, offering antiretroviral agents before exposure to HIV, such that the tissues are bathed in antiretrovirals and infection is prevented. Terrific effort went into biological plausibility. You asked about the science. The CDC actually led an effort to examine monkeys and demonstrate that monkeys offered different antiretrovirals would not acquire HIV, and that led to human trials, some done by the CDC, some supported by the NIH, some by others, and the trials pretty uniformly demonstrate that the agents have the potential to stop acquisition of HIV. In the end of the day, based on the trial results, the U.S. Food and Drug Administration approved the combination of tenofovir and FTC as use before exposure to prevent HIV acquisition. That's where we are today. We have one drug approved. It's worth noting at this meeting we're at today that lots of other things are being discussed and explored. And just real briefly, we're hearing about use of topical agents that could be used pre-exposure. We're hearing about injectable agents that could be used pre-exposure, some of which are very long-acting. We're hearing about alternative oral agents that could be used pre-exposure. So it's a pretty robust pipeline of ideas for pre-exposure prophylaxis.
And maybe it's Carl to talk next about what the role the government played in all of this, in the NIH.
Yeah, I'm happy to. I mean, I think we should roll back to actually the very first attempt to use antiretrovirals as a form of prevention, and that was the ACTG 076, which was essentially the prevention of mother-to-child transmission, where AZT, given in a couple of different ways, to the mother prior to birth, during the birth period, and then for 6 weeks after, was the first really significant breakthrough we had in prevention, chemoprevention. And from that basic idea and others, this concept of, as Mike says, the three ways to use ARVs to treat the HIV positive person, so essentially their viral load is zero, to prevent the virus from getting a toehold, and that can be done either with PEP or PrEP. This has been an area of intense interest because while we work toward an HIV vaccine, we need all the tools we can possibly put into the armamentarium to make effective combination prevention. That's really the goal of what this is about. This is yet another tool in the toolbox that we can then assemble depending on the nature of the epidemic. The other really good prevention tool we have is adult male circumcision, but it doesn't work for an MSM epidemic. It really is more for a heterosexual and generalized epidemic. So that's not a tool so much we can use here in the United States. But the combination of all these things will make a difference.
And I guess Jonathan's next with the role that the CDC plays, because you are part of that which is rolling this all out.
Well, the HIV epidemic is still a major public health issue for the United States. We have over 1.1 million people living with HIV in the country, And that's a 60% increase in the total number of people with HIV from 15 years ago. That same situation is occurring in many other countries in the world. And what that means is that we have to look for new technological solutions, new information, new ways of putting together programs that can together decrease the number of new infections and help people with HIV live the long and healthy life that they deserve. Pre-exposure prophylaxis, as Dr. Diefenbach mentioned, is one exciting new use of antiretroviral therapy that has been shown to work in a variety of different populations who are at risk for HIV. So it's been proven to work among heterosexual men and women, among gay and bisexual men, and among injection drug users. And so the questions that we have left for us now are the operational ones. How do we best determine who would benefit the most from pre-exposure prophylaxis? And how can we make it easy for them to take it and have it be effective? Because adherence to the medication has been an issue in some of the studies that examined it. How do we set up programs so that people who might not know about it can learn about pre-exposure prophylaxis and see whether it's right for them? And how can clinicians become both informed and comfortable prescribing it to patients? And these are some of the types of issues that CDC and state and local health departments are very comfortable with. This is our area of expertise. We take some of the technological interventions that either academia or NIH have brought from basic science to clinical research. We sometimes are involved with the clinical research in collaboration with other partners. And then we say, how can we make the biggest difference for the nation and the world?
And is that through demonstration projects or further research projects, or how would you identify those particular efforts?
Well, it's both. Some of the exciting research results that have been presented at CROI this year highlight some of the new drugs that may be used and the new modes of use of those drugs, like Dr. Cohen had mentioned. But also, Dr. Smith is heading up a program that CDC is involved with 4 different jurisdictions on really practical demonstration projects for pre-exposure prophylaxis to see if it works in the real world, and she could talk about that.
Yeah, maybe you could. This is your segue.
Yeah, I mean, I think what Dr. Merman is referring to is it's in a clinical trial world, or even in the trials that immediately follow a clinical trial. There's a very set way of doing things, and there's a set of resources that are brought in just to make it happen in that way. But now that the FDA has approved this for use in the general population among providers, there's not a clear understanding yet of how to incorporate PrEP into a primary care practice, for example, where you're seeing young men and women who may be at very high risk of getting HIV infected. But this is a new procedure, and it's unclear to many people how to make the jump from what was in the trials to what I need to do in my clinical practice. So, you know, how often do I need to test people for HIV infection? What safety testing do I need to do? How do I support people to adhere to the medication when I have a busy day and lots of patients? I don't have a dedicated counselor who can spend 45 minutes with a patient counseling. So we're trying to set up what's really like program evaluation or health services research. And so go to community health centers that are seeing high-risk populations where they're beginning to use PrEP and try to understand what it takes to do it in those environments.
It seems like I'm already seeing the evidence of people that are ahead of the curve and behind the curve. The population, there's a lot of people that are well informed. They're out there knocking on the door of health departments. Where's I want PrEP. And then on the other score, we have people that, what is PrEP? You know, so I mean, there's both ends of it. I think we really have to work both ends of it at the same time, to bring it up to speed, and that would be probably your segue.
Yeah, not Dr. Fukuda, just Don Fukuda. Thank you. I'm the director of the HIV's office at DPH. And, you know, it's a really, the questions that both Jono and Don were raising about sort of, you know, we know it works. We know that it's effective. The trials prove that. But in an implementation frame, can we operationalize this and make it effective? The first thing Massachusetts did, sort of after the results of the iPrex trial were published, is we pulled together an advisory group of providers and consumers and others in Massachusetts who could tell us, one, is this something that there's a demand for? Two, are providers ready to prescribe it? And three, do we think that the healthcare infrastructure has mechanisms to support people to be successful in utilizing PrEP? We really wanted to understand that before we sort of put forward any kind of plan. And what we heard from providers was that they weren't sure if they were ready to prescribe it. What we heard from consumers is they weren't sure if they wanted to take it. It wasn't for lack of faith in the science, it was for lack of experience with the intervention. And we're actually still there even in 2014, and Dr. Smith and I were talking about this moments ago. Now, Massachusetts is a bit unique in that we've already experienced about a 41% reduction in new HIV infections over the past 10 years. And that, we feel confident, is because of treatment as prevention. It's because of what was confirmed in HPTN 052. And we sort of had a lived experience of that. So what we're seeing in Massachusetts is people saying, we've maximized access to antiretroviral therapy, and yet there's something more out there that we can add to the toolkit. What we're really saying at the health department is, what's our role? So we did put a clinical advisory out from our Chief Public Health Officer, Dr. Al DiMaria. We did put out a frequently asked questions advisory. We did work with our funded, CDC-funded HIV prevention sites to make sure they knew they could utilize their state and federal resources to fund PrEP interventions. And so we're still following that course, but we feel like our primary responsibility as a health department is to ensure that if there are access barriers, that we address them, and that if there are capacity barriers, that we address them. And so training and technical assistance are still approaches we're undertaking. But we have not seen the kind of uptake of PrEP we would have expected in a state where 98% of our residents have health insurance. And we know, because we asked our Medicaid program, for example, to run coverage data, that they're covering Truvada as PrEP, and were covering it, in fact, as early as 2009, when the very early evidence that it was effective was becoming available.
Do you basically, how do you address this as a state? Is this more or less the specific heavy population areas, or is it?
It's a great question, and I think, you know, with a prescription like this that we hope is ideally offered and delivered in the context of comprehensive health care, it's a relationship between a doctor and a patient. Now, we certainly believe, and we continue in Massachusetts to see that gay and bisexual men and other MSM are the most disproportionately impacted population in terms of new infections. So we do want to focus on those sites that are serving those men. And so we have partners with those community health centers that are serving those men. Now, keep in mind, in Massachusetts, Fenway Community Health Center is here in Boston. They're a leading site in delivering this, and Dr. Ken Mayer continues to serve the majority of those patients in Greater Boston, either through research or non-research departments in that arena.
Can I add something?
Yeah, sure.
I mean, I think that what's interesting is kind of you're hearing like the science and the interest of the public health and community, strong interest, but a disconnect. And then the question is, where's the disconnect and what should be done about the disconnect? Yes. I think that to us, like now I'm going to represent the HIV Prevention Trials Network, the two biggest disconnects are consumer demand, which there's a belief that if you have enough big posters and advertising and information, consumer demand will exist. I'm not really sure that's true. We really don't understand. So if we accept that the problem in the United States is mostly among gay black men, and that's not, you know, that's not the only place to go, but that's a place where we really need to work on it. So we have a study called HPTN 073, which is offering gay black men opportunity for kind of a comprehensive prevention package, as well as the opportunity to take PrEP. That study's ongoing now in Chicago and Los Angeles. And if we find that they're not going to do it, we have to be realistic about it. We have to say, and we're obviously exploring, well, why are you not taking advantage of this? And they're being told that their chances about at least 6% of getting HIV, maybe higher. We heard a study presented here that between 20 and 24, it was 12% in San Francisco in a year, a 12% acquisition rate among that population. So we have the epidemiology and the data, and there's a huge, and we have a tool. And there's a huge disconnect between those two. So that's being explored, and I think that the results are really important, at least to us, to understand what's missing, and my colleagues can add to that. The second thing I think that's missing is, and this is important to me, all prophylaxis is time limited, generally speaking. Malaria, you're going to a malaria endemic zone. Surgery, you're going to have surgery. We give these things, but we haven't really figured out how to get people off PrEP At least I haven't figured it out. And that's a really important, or I should say a lot of people haven't figured it out. And we're trying to understand what counseling you give when you start people that will lead to a change in lifestyle that will allow this to be time limited. Because it's not, I don't think it's credible to say, here's these pills, you're going to take them for 20 years. And those are two, I hope that stimulates discussion, because this is just an opinion, really, and I'll stop. I hadn't even given a thought to that, getting off of PrEP. You know, you kind of, when you're told you're HIV positive, you're going to be on drugs the rest of your life. Well, that doesn't necessarily mean a person who is not positive. Of course, this should be time limited. Yeah. But the question is, so we talk about this endlessly. But I'm curious what Dawn has worked a lot on this, so I'm curious about her opinions of the things that I've just said.
Well, I think there's two things. I think it's different to ask people, do you want to be in a study? And to ask people when they're seeing their primary care provider, here's a medication that may help keep you uninfected, do you want to take it? So I think one of the barriers we have with young black MSM is that many of them have never heard of it. They don't know that this is an option. And many of the providers that they go to when they have a sore throat or any other kind of interval medication problem that they would seek medical care for, many of those providers either don't know about it or don't feel comfortable giving it. They maybe have heard of it, but they're not going to offer it because they don't know exactly what to do. So I think both the push and the pull have to happen before we can reasonably estimate what is the acceptability, what is the demand. And we're only a year and a half out from the FDA approval. And in HIV world, we're used to rapid uptake of drugs around treatment. But in the broader medical community, nobody would expect uptake to be very rapid a year and a half after a new drug is approved. And so I think we need to work on both more provider awareness and skill and comfort, and more awareness among the high-risk populations. I haven't talked to any drug users lately, but I would guess that most of them have never heard of PrEP either, and so they're not coming in and asking for it. So I think we have a lot of work to do in both of those areas before we really know how acceptable it's going to be.
Can I add something here? Because I think we're missing parts of this equation, and I think this is our challenge going forward. We're talking about the providers, but people get health care in lots of different places. We need to be able to get to the urgent care clinics, because a lot of young men, whether they're insured or not, will take advantage of that. Can the urgent care clinics around the country have posters up? Ask the nurse practitioner about PrEP, get a referral. So then you have a set of trained physicians that are associated with the urgent care sites in a given jurisdiction. The pharmacies themselves can play a role in this. So if there's signs in the pharmacy, PrEP can protect you. If there's signs, and the pharmacist is also informed. And so we have to get into the deeper reaches of the communities to be able to make this sort of a normative behavior that becomes a little more accepted and easier for people to access. So if they see it on a bus, if they see it in the pharmacy, they see it in the urgent care clinic, it's not quite so scary. And then people will be a little bit more comfortable asking questions. And really what we need is the Malcolm Gladwell tipping point, where we get the early adopters to either sing its praises or not. And ultimately that's going to drive this. And we can do the great social experiments and trials, but ultimately that's what's going to determine whether or not there's uptake. And it may not be off of your FTC. I think that what we're going to have to do is look at other possible agents that may have slightly different side effect profiles. Because like with antiretrovirals, not every antiretroviral is right for the right person. But I think we really need to take we're taking this as a very public health model, and it's almost like we need to treat it more like it's like diabetes or chronic heart disease, where it's not really public health, but really driven by physicians and pharmacists. Because I think if it stays within the STI clinics and those places, it's really going to have a limited outreach.
So two issues come up that I think are essential for kind of PrEP implementation that colleagues raised today. One is that adoption takes time, and sometimes it depends on having a variety of options that meet someone's needs. So the parallel to contraception is there, that some people like oral contraception, some people like IUDs, some women prefer using condoms, some prefer using a diaphragm. Having different options that meet different people's needs and desires can sometimes help people adopt what can be a very important health protective intervention for themselves. But right now, we don't have as many options as you would for some others. And then I think the other area is really how do we make assessment of risk and helping people understand that this might be a beneficial intervention easy. So one of the challenges for PrEP is to prescribe it, you have to talk about sex. And to talk about sex, you actually have to talk to your patients about what kind of sex they have and with whom. And so that's not as easy as talking to someone about their high blood pressure or their potentially elevated cholesterol. This is, to be able to prescribe PrEP, you have to either ask questions about people's sexual behavior or have them bring it up. And it's very intimidating for patients to go to their doctor sometimes and talk about their sexual activity without feeling judged, and for clinicians to be experienced enough not to inadvertently judge their patients. And so some of that limitation will continue to occur until we work with the healthcare system to make collecting sexual histories and talking to people openly about sometimes difficult conversations comfortable.
Or even removing it from the conversation. I'm always struck when I go to the doctor, they give me this little sheet to hand out, that I have to check off, did I ever smoke, how many cigarettes did I smoke when I was younger versus now. All these things which, first of all, I'm not sure why I have to answer them every time I go to the doctor, why they can't keep a record. But the second thing is, maybe some of these questions can be put into a format like that where it's not so embarrassing, and where the provider can just look at it and say, oh, okay, so I see that, this, let me ask this question, and then we'll know how to help you protect your health.
There's another thing, and people that aren't used to taking pills every day, like people who are living with HIV are used to it. That's the way it is. That's life. But a person who's not taking treatment every day is now going to have to take treatment every day, very, very purposefully. What about the new pipeline drugs that are now going to be once a month or once, 2 months? That might be another consider. I mean, the company's already talking about that. This might be a good PrEP.
Yeah, so the two drugs, rilpivirine and an integrase inhibitor called GSK744, both companies are pursuing with NIH collaboration and by themselves, which always happens. There's independent phase 2 trials and there's NIH-supported trials that are ongoing. They have numbers and teams, and they're all just about ready to go. They're phase 2 safety studies. Now, remember, we're going to inject agents that last a long time into HIV-negative, healthy people.
They're still going to have to take them.
No, hear me out. There's a very important, so it's great that we're cheerleading development of these drugs. It's appropriate. But we have to prove they're safe over a very long period of time. So the studies are being designed for several months, 9 months, I believe, 8, 9 months of participation in the active arm where you're getting the injection, and then in a whole year of follow-up as appropriate proof that they are safe and non-toxic and well-tolerated. If that happens, then a phase 3 efficacy trial, which will be both efficacy and effectiveness, will be done. It's efficacy and effectiveness because if we're controlling the injection, we'll see does it work in both the real world and the experimental world at the same time. That study would be, I think, supported by the NIH. It's being planned already. Very complicated study, and which populations to be tested on, the highest risk populations. And it will have to be a global trial, right? It would, while I'm very sensitive to the United States, we really have an obligation, I think, as investigators to work with the highest risk people in other countries as well. So you can kind of see not just the pipeline. Those two drugs are available, ready for phase 2 testing. It's starting in June. Actually, one of the trials is starting next week. It's really going to happen. And then will we test both drugs, rilpivirine and the integrase inhibitor, or will there be one winner? And that'll all be determined. Now, there's one other thing to throw into this conversation. There's other possibilities. You heard at this meeting about monoclonal antibodies called broad neutralizing antibodies. Those antibodies last for months. They're expensive right now to make, but they are a competitor for antiretroviral agents because they would last several months. And so you can kind of see if they were broad enough and safe enough, and we've done a lot with monoclonal antibodies over the year, you can kind of see, well, they could be a competitor too for pre-exposure prophylaxis for the highest risk people. So it's a kind of an exciting time, but this will take a minimum of 4 or 5 years before the injectable agents are ready to be in the marketplace. Accordingly, I don't think we have the luxury of waiting 5 years to work on this when we have many thousands of new cases of HIV in the United States and hundreds of thousands of cases among young women in sub-Saharan Africa. So I do think there's and I don't want to use the word urgent, because my friend Dr. Diefenbach hates it when I say that, but because it implies that we're going to do things sloppily. You cut corners. He hates it, so I apologize in advance. But we do have a sense of action that we really have to not just wait for another agent, because we don't know what's going to happen.
But the other way to think about it is that everything that we learn in trying to implement the currently available PrEP method and trying to identify the right populations and get them aware and get the providers aware and comfortable is transferable to whatever that next new agent is. Mm-hmm. And so we need to start getting the experience of how you do this well. And then when the next thing comes along, if it's an injectable or a gel or whatever it is, we'll be that much further along. We'll say, we know how to do that.
Agreed.
So
I think some of the agents you mentioned, the injectables, are still going to have to be tested sufficiently so that there is not orally, so there is not that sense of you have something in your body now that your body rejects. The sense.
Well, I think we're done with that essentially. We're done. That's been done.
Yeah. Okay.
The rilpivirine, more than 1 million people have taken the agent rilpivirine, and the integrase inhibitor was reported at this meeting 1 hour ago as orally safe. Now, it was presented in a slightly different format, but it is almost certainly safe orally. Yeah. There is another issue that, since you like the details at some level, there is another detail that is going to be a really important detail. With the oral agents, you stop them and they're going to disappear in a couple of days. With the injectable agents, we have a problem called the tail. What's the tail? Because they last so long, when you decide to stop them and come off the drug, there'll be a window of time when a subtherapeutic level of drug is in your bloodstream. Having said that, the subtherapeutic level, then what we are risk if a person acquires HIV, resistance to the agent. Yes. We're challenging the bug with a subtherapeutic amount of drugs. So we're really into worrying about what do we do about the tail of the injectable agents, if that makes sense.
So you still have to evaluate the patient, you have to test the patient regularly.
Yeah, absolutely.
So that if they are infected.
It all comes back to the need, no matter whether you're taking HIV medication for therapy or prevention, you must adhere.
Yes.
And so I think that is the bottom line, and the solution is, even with the tail, either they have to go back on pills for a while to cover the tail, or they have to get another shot. And that's going to be the challenge to the health departments, to be able to track these people down so we don't essentially create a new generation of drug-resistant variants.
Gentlemen and ladies, we have done a good job on, I think, presenting the science to implementation in PrEP, pre-exposure prophylaxis, and I appreciate you all for being here. This has really been a rewarding experience for me. Thank you.
Thank you.
Thank you.